You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Today's episode of The Dish on Health IT features Neikisha Charles, Director of Quality Improvement and Risk Management at Bedford Stuyvesant Family Health Center, a federally qualified health center in Brooklyn, New York. She joins Tony Schueth and co-host Rob Dribbon for a conversation that takes on some of the persistent myths about FQHCs. Listeners will learn how these community-based providers are leveraging technology, rethinking care delivery, and offering real value as partners across the healthcare ecosystem. If you think of FQHCs as outdated or disconnected, this episode might just change your mind. Have a topic you'd like us to cover in a future episode? Reach out to us at podcast@POCP.com or fill out our form on the podcast page under Insights section on POCP.com.
Welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners and your host for today's episode. If you're new to the show, this is where we serve up hot takes and deep insights on the challenges and opportunities shaping health IT today. We're diving into federally qualified health centers, or FQHCs. These community-based providers are often mischaracterized as tech-poor, under-resourced safety nets. But that's not an accurate picture. FQHCs are evolving, tech-enabled, and playing a crucial role in shaping how care is delivered in communities across the country. Joining us today is Neikisha Charles, Director of Quality Improvement and Risk Management at Bedford Stuyvesant Family Health Center, or Bed-Stuy, an FQHC in Brooklyn, New York, serving a diverse and vibrant patient population with innovative care approaches. And I'm also joined today by my co-host, Rob Dribbon, a consultant here at POCP on our life sciences team. Rob brings decades of experience in pharmaceutical marketing and strategy. Neikisha, Rob, welcome to The Dish on Health IT. Now, Neikisha, let's start with you. Tell us a little bit about your journey, what led you to your role as Director of Quality Improvement and Risk Management at Bed-Stuy, and what drives your work in the FQHC space.
Thank you for having me. Hi, Rob. Hi, Tony. I am, as previously mentioned, the Director of Quality Improvement here at Bed-Stuy Family Health Center in central northern Brooklyn. I got to Bed-Stuy in 2021, I guess at the end of COVID, and I came here as the healthcare data analyst. So I do have a very strong data background. I previously worked in healthcare, in geriatric healthcare. So that was like a whole 12-year span. So I've been in healthcare since I left college, and I did go to college in Brooklyn here, CUNY Brooklyn College, and received a bachelor's degree in biology, and went on to further achieve my master's degree in public health from George Washington University. So my role, my ascension into the role of Director of Quality Improvement started with my acumen for data, my veracity for consuming the multiple points of data that we collected, noticing that we didn't leverage the data well enough, just collected a whole bunch of data and didn't do much with it. So I started using the data in my role as the healthcare analyst at that time to improve on the measures and the outcomes, and to work collaboratively within teams to ensure that we were meeting the standards and the outcomes using the data that we already had collected. My boss at the time, who's now our CEO, saw the potential and said, you know what, I think you'll be perfect for the role of Director of Quality Improvement, given your strong data sense. And that has led me to work within this milieu here at Bed-Stuy Family Health Center.
That's great, and I'm so glad that you bring those skills to the team. It's much needed. Rob, can you give the listeners a quick snapshot of your background, especially the work you've done advising life sciences companies on strategic engagements across the healthcare ecosystem?
Sure, Tony, and hi, Neikisha. The vast majority of my career I spent at Merck. working in a variety of areas like strategy, business development, alliances, sales, marketing, and also worked both domestically and internationally, and it did quite a bit of work related to underserved populations, which is quite relevant to today's discussion. Also, after Merck co-founded a startup called Polygon Health, and also have been a consultant working with Point of Care Partners on a number of different projects and initiatives, many of which are in the life sciences sector. So really happy to be here today.
And we're delighted to have you here as well. Let's level set for the listeners, especially those in health tech, life sciences, or payer roles who may not know all the details. Neikisha, can you define what federally qualified health centers are and explain how they fit into the larger U.S. healthcare system?
Yeah, so federally healthcare centers, though established, are kind of an anomaly in the healthcare space. In terms of knowledge base, right? A lot of people don't know necessarily what we do, who we are, and where our charter comes from. So we are federally funded as federally qualified intimates under the Public Health Services Act, Section 330. So we receive our funding primarily from the federal government, HRSA, the Health Resources and Services Administration under the HHS. And we're mandated to serve all residents of our community and operate in primarily underserved, underserviced areas. So we are safety net providers that focus primarily on primary care in addition to other services. That makes healthcare accessible to members within our communities and removes strain from the emergency system and other parts of the health ecosystem. So we are operating with a different consciousness than a lot of other parts of the health ecosystem operate. So we operate within with the knowledge of our patients' social determinants of health. So we are socially conscious and whole person health focused to remove barriers to accessing quality care for the denizens of our communities, which are usually rural populations, urban populations, migrant populations, homeless populations, and generally underinsured or uninsured populations.
A much needed role that you play in healthcare. Rob, is there anything that you would add on why folks in our audience should pay attention to FQHCs as serious players in healthcare?
I would just, I guess, emphasize the important role that they play within the community. It's really vital in so many communities across the country. And the populations that they serve, the holistic approach and comprehensive approach that a community health center has on its population is, I think, quite unique when you think about the way healthcare is delivered in the U.S. If you can go to a place, one site, if you will, and find more than just, let's say, primary care or some subspecialty, all in one building, so to speak, it's pretty powerful, the type of impact that it could have. So very impressive set of community health organizations that we have across the country. And Bed-Stuy, certainly, at least in my experience, is really a standout.
Without a doubt. So there's a common belief that FQHCs only serve people who are uninsured or unhoused. Can you paint a more accurate picture for us? Who are the typical patients you see, Neikisha, and what kinds of healthcare needs are you helping them to address?
So we, and this can be verified by going to the HRSA website. Any data I share is public knowledge, right, and public facing. So we are mandated to report on a metric system called the UDS, which is the Uniform Data Set, that we give data back that we've collected to the federal government to justify our continued funding and to show what outcomes we are meeting. So within that data set is demographic information, financial class breakdown for our patients. So most of our patients belong to some sort of Medicaid managed plan. So that's a bulk of our patients, many being minorities, a bulk of our patients also within the Bedford Stuyvesant Family Health Center, within our network of 3 health centers. We serve primarily African American, non-Hispanic patients. However, those aren't the only patients that we serve. We serve patients who are commercially insured also, patients who are uninsured also on a sliding scale. So in this landscape, we do occupy a very specific niche of providing need for all residents, the healthcare need of all residents of the area that we cover. Part of what we do is, primary care, a lot of mental health services that we do provide, both via in-person and telehealth, connecting services that help patients with referrals for social needs of food, transportation, and things of that nature. We also have, specialties, dental, we do podiatry, we do optometry, we do a lot of chronic care to improve patient outcomes, to match with the goals that the CMS has set for us or that our other funders have set and that are in line with achieving a healthy population.
Much, much needed. I think I'm going to say that many times over. Rob, in your experience, what do you think the misconception is? Does it persist? And what's the risk stakeholders keep holding on to?
Well, I think that organizations that go to market, if you will, a certain way, tend to hold on to that just because it's the way they've gone to market for many, many years. And if your typical approach is with your, health systems out there, the community health organizations might be missed in the view. And I think there's certainly ample opportunity for organizations to ensure that they really understand the impact that these organizations are having within the marketplace and identify areas of collaboration where an organization can come to the table with tools, resources, and other ways to enhance the care that gets delivered to the populations that these community health centers serve.
So Neikisha, speaking of collaboration, what's your pitch to health IT vendors, payers, or life sciences companies who might overlook FQHCs as potential partners or stakeholders? What are they missing?
They're missing ample opportunity and space to collaborate in a meaningful, strategic ways that are beyond transactional. By that, I mean sustainable, sustained engagement. We are, and I think I get a feeling in various other forums that there's a misconception that, we're data poor. We're resource poor, we're tech poor, and we're not tech poor. We have a lot of tools available at our disposal that can work well in this space if developed well and leveraged properly. Like we have software, we have database, we have platforms that we use that some other health systems haven't learned to leverage as yet. So there's ample opportunity to learn and to grow with us and to make meaningful change. I think the meaningful strategic relationship is the part that is missed, because in most instances, the human resources at FQHCs are people who've been there for years and who are vested in innovation and in change and in betterment for our population that we serve. The patients are also deserving of these improvements and things that ease their access within the health system. So, we have currently partnerships that, leverage a lot of tech tools to improve outcomes for our patients, patient outreach tools, patient engagement tools, testing in the life sciences space. We do a lot of good work that is, if leveraged properly, sustainable. So there's an opportunity here to develop within a very compliant space also, because, we have a lot of people that we have to report to, and we dot our I's and we cross our T's very well. But that doesn't limit potential collaboration. You have a reservoir of information and resources that you can use.
And Tony, I'll just chime in there because I think Neikisha raises a really important point about the regulations and it's government funded, if you will. So back to the point or the question you asked me before, Tony, about what might be some of the challenges or misconceptions and why it might not be as much of a focus area as it should be for some of, let's say, life sciences companies. Another reason could be that because of the rules and regulations that are associated with government funded and government run programs, some organizations might be a bit more reluctant to engage. So I think, as Neikisha put it, sure, there are rules and regs, but there's rules and regs everywhere. And there's an important need for people to understand what those regs are and how to play within compliantly within those regulations. And once you understand the rules, the boundaries, it demystifies it quite a bit and enables a conversation that could lead to a real fruitful outcome. So I think that might be another maybe perceived barrier out there that it might be helpful for people to take a look at and see how they can really engage within the rules of the road.
Neikisha, your organization integrates primary care, behavioral health, and community services. How does that intersection shape how you think about delivering care?
So I think, and I refer to our model all the time as FUBU care. I call it for us, by us care. So for the most part, the people who work here are in leadership roles here are members of the community, right? So we understand acutely the needs of the people that we serve. So that intersectionality of, persons, of things, of resources, gauges and shapes the way that we deal with the person. So in our instance here, we're a patient-centered medical home where we are chartered to provide services that are comprehensive for our patients. So a patient may come in for primary care, but they're experiencing some other difficulty socially, and we have social workers who are able to refer them to these services, someone who can help them fill in a form that they may not readily access if they enter another health system, a different part of the health system, like go just somewhere else for primary care. We're able to assess the need and try to deal with the need at the visit, considering the person's health holistically, a whole person view of an individual who encounters us for any type of healthcare. And I think that's what separates us from a lot. It's not just in a prescription out, come back for a follow-up. It's, I'll call you to give you results. You can come back to see our patient advocate to discuss your housing situation and see how that can be helped. I can offer you a testing kit from a company, a life sciences company that we have an existing MOU with, that we're able to offer you without insurance a screening kit for free that you may not ordinarily, if you go into another health system, be able to encounter. And these are the things that we do differently here. We're able to leverage a lot of our good in these working relationships with these companies that we use, tech, IT, life sciences, you name it.
It's impressive. Rob, how do you see this integrated approach influencing opportunities for health IT or pharma partnerships?
Well, I think it always starts with the patient, and the way in which the community health centers like Bed-Stuy approach it is very patient-centered, and that is quite aligned with the mission of life sciences companies, certainly the one I used to work for, and also health IT organizations that are trying to support the improvement of health care delivery throughout. So when you align yourself with an organization that is patient focused, that's taking a population health approach, holistically, like Neikisha said, comprehensively, it really does represent a significant opportunity for life sciences, for health IT organizations, I think over 30 million people are served by community health centers across the US. I mean, that's 10% of the population right there in this one segment of the marketplace. So it certainly is, I believe, a significant opportunity for collaboration that could result in better, population health management, better patient-centered care, and align with many of the goals that the organizations have. So I think it does represent a significant opportunity.
I think so too. So there's a perception that FQHCs are under-resourced and behind when it comes to technology. But Neikisha, that doesn't sound like Bed-Stuy.
Some other FQHC, not Bed-Stuy Family Health Center. No, we're well resourced. We're tech connected, and we leverage these resources to improve patient outcomes.
Can you give us some examples of digital tools or solutions that you're actively using to improve care or streamline operations?
So we use ECW as our EHR, which has, and that's eClinical Works, which has multiple tools for population health management, which has multiple integrations with different population health management companies. There are plugins that, when the provider is seeing the patient, any screening that needs to be completed, there's a pop-up. It's very integrative and interoperable, these systems. So ECW is one of these systems that we use. Outside of that, for our population health management tool, we use Azara Drives. And what that does, it's ports information from ECW or whatever EHR, it is vendor agnostic, I believe. And it comports that information into different measures for different standards. We have different dashboards, different visualizations, different reporting metrics that it completes and compiles, and we can run reports from there for our funders, for our stakeholders, otherwise, for our patients, for our providers. So it's very integrative. We also use another communications platform called Artera. It's the Well app, for our patient reminders, for campaign notices, just general two-way communication with our patients, because we historically had an issue that we had to resolve where our patients were complaining that they would call us and are not able to reach us readily. So that old way of depending on the phone system became, strenuous for us. So we had to move into finding a solution. And that's what happens in the FQHC space. We identify problems and we identify potential solutions, and we do PDSAs or cycles to figure out, what is the easiest way to remedy this. And we find the best tools that are at our disposal to remedy our patients and our internal issues. So we do work diligently to ensure that the healthcare experience here at Bed-Stuy Family Health Center, and most FQHCs do, is as seamless and as barrier-proof as possible. With the patient communications outreach, we use that to close care gaps. If you're a woman of 21 to 64 and you need a mammogram or you need a pap smear or you need some form of screening, we can communicate with you outside of your regular visit to give you that information. So these are the tools that we have at our disposal that we leverage to close gaps for our patients and to ensure that they have the best outcomes. So we're definitely not under-resourced when it comes to technology. And we do work on partnerships speedily to implement change for our patients.
Rob, you have a broader perspective. What stands out to you from a health IT perspective about FQHCs and how they're using technology creatively?
Well, in my experience of engaging with FQHCs across the country, I think that it's quite impressive how they have been utilizing technology in that holistic way that Neikisha's talking about, thinking about the patient and their journey across the board, and ensuring that the opportunities and any gaps are addressed as quickly as possible. It's really interesting and quite motivating to see how FQHCs, like for instance Bed-Stuy, can utilize technology to get people engaged in their own healthcare when otherwise they might not have even chosen to engage in the first place, leading to the completion of, say, a screening test, which could in fact lead to a better health outcome. So or avoidance of disease, as an example. So I think that the opportunities exist for, as mentioned before, for health IT organizations, for life sciences companies to partner with these FQHC type organizations with so many aligned goals along the way.
Neikisha, you mentioned in the beginning that you kind of got your start in healthcare in the data field. So let's dig into data sharing. FQHCs often coordinate with hospitals, specialists, social services, and more. How are you tackling interoperability challenges?
So data sharing and interoperability in the FQHC space. So I think it starts with having the right human resources involved in the process. So we need people with the requisite acumen in the positions that enable those arrangements to come across more seamlessly. So in our instance, and most FQHCs have a director of health integration, or they have a chief of health integration. So that's like on the hierarchy, that's on the chart. So we have someone responsible whose responsibility it is to ensure that we're engaged in as many meaningful partnerships or interoperability as possible. So federally, there was a mandate that all the data that I referred to initially was going to be, we do it manually now with some uploads, but that UDS report was going to move to UDS Plus, which was totally a FHIR integration. So it would have been a direct interoperable. That kind of stayed for a while. There are some things in that process, but that is where our world is moving to seamless transition and transfer of information. So for us, we engage with a lot of our partners, a lot of the places that we send our patients. We do have data sharing agreements with them, so we're able to have read-only access to their EMRs. So if a patient had a procedure, if we refer a patient for a procedure somewhere, we're able to kind of log in and get that information before the patient comes back for the next visit and upload that to the chart seamlessly. We engage in those strategic partnerships through, I guess, our network. And we do have like a health center control network, and we have PCAs that we belong to that kind of maintain that we should make data sharing as seamless as possible. So we're connected to our HealthX Rio, where we get information on our patients, transition of care. The same software that I mentioned as our drives, they have a transition of care reporting tool that is integrated with HealthX also. So we kind of all get our information from the same spaces. I guess the challenge comes in ensuring that we kind of consolidate that data sharing and data gathering, because it's very compartmentalized as it stands. And a lot of these things are not necessarily agnostic, vendor agnostic. So moving to that level of interoperability will be like where I see the space moving. But we do well with what we have.
Yes, you do. And no, we are not as vendor agnostic as we'd all like to be. So Neikisha, also in the sort of data world, data is central to funding and quality reporting for FQHCs. How are you using data analytics or dashboards to support both care delivery and your business operations?
So I'll give you an anecdotal story.
Great.
So I remember I was the data analyst. So we were in charge on, this is the life cycle of how the process kind of works in here, right? So the patient comes in for a visit. The information is put into the EMR. I mentioned Azara prior. So that data is taken and turned into dashboards and measures based on technical specifications and value sets and all this hinky data stuff. So my duty was to monitor that data. So I did notice, that our colorectal cancer screening rate had decreased from 2021's performance, and I'm noticing this in 2023. So I looked at it, I went through the data, and I'm trying to figure out how to use that data to enact a meaningful change and improvement in performance. So improvement in performance means a lot of things. So the number goes up, but it also means that more patients are screened against colorectal cancer, giving them better outcomes. So I looked at the colorectal cancer screening performance rate, and I saw that it was declining instead of improving. And then I remember that we had a MOU, right? Remember, we're at FQHC. So we had a MOU with a life science company, Exact Sciences, who makes Cologuard, right? So because we're in the FQHC space, we're able to negotiate and work with them to exchange data on the patients and to receive their testing kit through insurance for patients who are insured, or through the patients assistance program for patients who are uninsured or underinsured. We leveraged that working relationship, that data, to come up with a text campaign to invite our patients using that same Azara run from that same measure who are non-compliant from that measure, the opportunity to receive a Cologuard kit by mail. So remember, we were able to text them through our platform. The measure is well calculated because it's technically sound, because we use a tool that does that really well, and we can text our patients from that measure also. So what happened in that space of time? We initiated that campaign on May 1st, 2023, and our compliance was at 48.3%. Directly as we initiated that outreach campaign, that text campaign, our compliance shot up. That trajectory of that, and you can see it across a dashboard that's present in Azara. And in 18 months, our compliance for colorectal cancer screening shot up by 12.3%. So now we're in the 60s.
That's awesome.
So we leveraged that tool, we leveraged that data, we leveraged that partnership, that strategic relationship that we had with Exact Sciences, that data that we had within our EMR, that reporting repository for population health that we have, that is Azara Drive, to directly improve a patient outcome. So that's what FQHCs are able to do that a lot of spaces are not able to do.
What a great example, though, of how you've been able to work with the industry to sort of come up with a solution that really had a meaningful impact and a measurable impact. Rob, is there anything you'd add to that?
It was the evidence is there. The numbers speak for themselves, and the way in which Neikisha described the approach from a health IT perspective and a partnership perspective with, in this case, a life sciences organization, really was impressive. And again, it all starts with the patient, and that taking that patient-centered, patient-focused approach made a difference here. And it's not just about the technology. It's also about the meaningful relationships that are being built at the community level with the community health center and the patient population. Like Neikisha said earlier, the technology helps to identify the opportunities. Without it, wouldn't be nearly as effective or successful. But it's also about the relationships that are being built at the community level. Like Neikisha said earlier, they know not only about the patient's health history, but they also know about their housing housing situation, their food challenges, and other economic challenges that they might be facing. And that's the whole person. That's that patient-centered medical whole person approach that Bed-Stuy and other federally qualified health centers take. So really, really good stuff.
Neikisha, one of the things that you talked about in the beginning is how you're also using telehealth. So let's turn our attention to that for a second. Telehealth saw a huge uptick during the pandemic. What's the role of telehealth now in your organization? Are there patient groups it works for especially well or poorly?
Yeah, so telehealth, as you mentioned, surged, and its usage and its expansion surged during COVID. So in COVID, we used it a lot for our well child visits. Babies weren't able to come in. So, we did telehealth a lot for our well child visits and for behavioral health services and results follow-up. So now we leverage telehealth a lot for behavioral health usage here. That's primarily how we use telehealth here. Counseling sessions, medication management, just behavioral health interactions we really benefit from the usage of telehealth for behavioral health. So that's primarily how we use it here now. It's expanded to a big part of our behavioral health program.
Got it. It's powerful for that role. Neikisha, where do you see the biggest gaps in technology solutions for FQHCs? What do you wish vendors or partners better understood about your day-to-day challenges?
I think vendors, have to understand the space within which we operate. The realistic application of, the things that we do and the people that we serve. The gaps are, again, in interoperability, I think, for data purposes, but in general engagements, I think that the gap is in information and education on what really happens in an FQHC. And I think programs like this and podcasts like this, shed a light on what the FQHC space presents. So technology companies and life science companies, they have a lot to offer us, but they have to tailor their products to us with engagement from us. So, understanding what our needs are, what is your mandate? What are you mandated to do? Or how do you need to comply? Whom do you serve? What are their biggest needs? Don't try to sell us a product that is not, or to engage us in a relationship that is not beneficial to the bulk of everyone. Give us something that we need and that we can leverage over time strategically to improve the outcomes for our patients. And I think that's mainly what needs to be done. Give us what we want. Not what you have to sell us, but tailor something that we need to us. We need things that make it easier for us to contact our patients or for our patients to contact us. We need tools, or we need engagements with life science companies that make it easier for patients to screen for certain tests, or may give us, something that assists us in getting our patients here, after a long time, engage us in these partnerships, engage us in the way that is most beneficial to us. Just don't sell us something that you want to sell.
So Rob, outside of this podcast, what are other ways we can educate the industry about what FQHC's needs are?
Yeah, sure. I think, like Neikisha said, it's not just about the product that's being sold. It has to start with the patient, and the alignment between the FQHC's mission as well as the industry, life sciences, health IT organization's mission. And if you could find that sweet spot between the two, it could lead to some really interesting, effective types of collaborations. I think, as mentioned earlier, the rules and regulations can sometimes dissuade organizations from engaging because it's a bit mystical in terms of what those rules and regs mean, how they manifest themselves in this segment. And some organizations might just, keep clear of it. There's also pricing and discounting related challenges with this market segment as well. And a lot of the discussions have focused with this segment in that area around discounts. And if you could pull back from those discussions a bit, and bring the discussion up to a level where you could see the broader picture about how two organizations can come together. And if working together, they could actually achieve more than each individual organization could achieve separately. So I think providing a better understanding of the view from the FQHC perspective, the challenges that they have in front of them, and then also the boundaries that they play within. If you could understand all of those elements, an organization like Life Sciences or Health IT could come to the table with some meaningful collaborative suggestions on how to work together.
Well, that's a really good way to sort of wrap up and summarize, Rob. So as we wrap up, Neikisha, the floor is yours. What's your biggest hope or biggest ask for how health IT industry or life science manufacturers could better engage with FQHCs moving forward?
So first, it starts with trying to engage, right? Attempting to actually engage. So reaching out, and then coming up with meaningful strategic arrangements, meaningful partnerships that are sustainable, that are data-driven, and that are patient-centered. And I think there's a whole space within the FQHC world that presents ample opportunity for companies in IT and life sciences to engage on a meaningful level to gather information. So it starts with information gathering and understanding the settings that we operate in, which I alluded to, referred to prior, and getting you a point person. At Bed-Stuy, that point person is me. Getting you a point person within the world that you're trying to engage with, and just coming up with a plan and selling a product or presenting a product or presenting a service that is of benefit to the patient. And the mutual benefits will kind of unfold on their own just during the course of our engagement based on how we operate. So I think we present a world of opportunity that is underutilized and underimagined for. But we're here, and we're kind of here to stay. Like we're chartered. We're here. We're sure. A sure and a safe space for development and engagement.
You sure are. Rob, what's the last word from you? What would you like our listeners to take away from this episode?
I would say a sincere appreciation for the work that the community health centers are doing for the populations they serve across the country. As mentioned, 30+ million people across the country utilize the services of community health centers. They certainly are a force to be reckoned with, and with technology being implemented effectively by organizations like Bed-Stuy, and that holistic, comprehensive approach that they're taking, understanding the community, understanding the people within the community, what makes them tick, really is quite powerful, and I believe represents tremendous opportunity for partnerships and collaboration to always put the patient at the center and make some really good things happen.
One of the things I always say is that we're all patients. So I really like that, put the patient at the center. That's super important for everybody in healthcare. So huge thanks to Neikisha Charles and to my co-host Rob Dribbon for an eye-opening and myth-busting conversation. To our listeners, if this episode gave you a new perspective on FQHC, share it with your colleagues or clients. Like Rob said, this is an opportunity to sort of educate them on what the needs are of FQHCs. And don't forget to subscribe to The Dish on Health IT wherever you get your podcast. So until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with fire accelerators? Email us at interopoutlook@pohcp.com to learn more about our Interoperability Outlook subscription monitoring service.